Okay, we have a case here. Again, very typical case. We're missing tooth number 30. Patient's probably been missing this for a little bit of time. And the patient's ready to have a tooth there. The specific question, and I love it when we get a case that has a specific question, is can I go with a longer implant or am I too close to the nerve? So the first thing I think about when I have this question is one, are we doing it guided? And obviously in this case we are, so that gives us more room to be more precise, okay? Number two, I think about the system that we're using and the drills that we're using, because remember, the drills are a bit longer than the implant. So if you're using a 10 millimeter implant, we might have an 11 millimeter drill. If we're using an 11.5 millimeter implant, we're going to have a 12.5 millimeter drill. The third thing I think about is where exactly is the nerve. So when we have these questions, the first thing I like to look at is the nerve mapped? So, in this particular case, it's not. So, it's pretty easy to see here the nerve, but again, just being, critical as I am, I would prefer to, in a case like this, get the nerve mapped. And mapping the nerve, so this will be a good opportunity to go through that exercise. My preference in mapping nerves is to just map the area of interest, no reason to map the entire thing. I like to work from the mesiodistal view, the cross-sectional view here. Here we can see the nerve quite easily. So again, let me just take my pencil tool here and we can kind of see the area that I'm referring to. We like to have that there. Again, so let me draw this for us here so we can see that area as the pencil tool, as the nerve right here. So, I like to have that area. So now we'll go to the nerve tab. And, basically what we'll do here is we'll just mark the nerve and move through. So we're going to be working on the right hand nerve. Make sure my license is there. And again, you see that was grayed out, so the license wasn't available. Simply come down here, click the license. So now we have the nerve point. So we're going to go ahead and double click in the center of this area. We're going to continue to move forward, double click, move forward, double click, move forward, double click, move forward, keeping an eye on the canal right there, double click, move forward, double click, move forward, double click, move forward, double click. And for me, that's pretty much all I would do for this nerve mapping right there. And now we have a good nerve mapping in this particular case. So now when we come to the implant line view, now we can clearly see our nerve here, which again, these little things are maybe overkill, but again, just in the very beginning, I prefer to have this data there. So now let's get to the question at hand. So first thing I look at is buccolingually. We're not perfectly centered, but that, again, it's not about being perfectly centered. It's about being properly in the bone, having adequate bone position around it. And in this particular case, we do. We can see that this patient has probably lost this tooth and had some resorption by the slope of this. We're making the assumption that this implant crown was drawn, the margin was drawn correctly. So I would say that buccolingually, we're passing fine here. Mesiodistally, generally speaking, we look for it to be centered. In this case, we obviously see that it's not centered, but it's not about just being centered. It's about having adequate distance between the teeth. We can see that this tooth number 31, we'll call it, is quite a bit tipped and the roots are curved, so we can't expect it to be centered. What we're more looking for is we have the adequate space between the root and the implant and that we're supporting the tooth properly. Next, let's look at our occlusal table. Okay, and we can see that this implant right here is coming out of the center of the tooth, pretty much dead center. The mesiodistal direction looks pretty darn good. And then let's look at the occlusal plane, which is right here. And this is the area where I would say maybe, just maybe, we can be a hair better in the sense that I think, and looking at this, occlusal plane is a bit this way. So to help people understand what it is I'm referring to, I think our occlusal plane, if we would draw a straight line across here, we would see that the occlusal plane looks like that. And I would think it's safe to say that I would think that it's safe to say that we don't want our occlusal plane to be like that. We'd like it to be more flat across. So let us go ahead and take a closer look here. And I think if we tilt the implant that way, we're going to get a better occlusal plane now and still be okay. So now we need to go ahead and tilt the implant there. So getting the occlusal plane to be perfect is going to be difficult in this particular case. So we will go back with it, and I see why we were done this way. So again, the goal is to test, to see what's going on, and then make that decision. So in this particular case, it was properly done. Next, we look at bone level, and again, if we take a closer look at this, we can see that we're subcrestal. In an ideal world, the implant is right there, but there are two things that worry me about this particular implant position right there. One is we're a little bit out of the bone right here on the buccal, thinner tissue with resorption. Very likely that that implant grayness will show or will require grafting. And the other issue I have, more importantly, is the emergence profile. How are we supposed to develop a nice emergence profile from an implant this high? So in this particular case, the plan was done correctly. To place it a little bit deeper, even though we're going to go subcrestal right here. But in doing the drills, we'll see that we're going to actually get rid of this bone and do the ostectomy of that bone there. But more importantly, now we will have the ability from the platform to properly develop, our emergence. Now, properly develop our emergence. Whereas if we had this implant, more right here, you tell me how are we going to develop our emergence? It's going to have to come out like that, giving us a little bit of a bulkiness there that I don't think that we want, and same right here probably be okay. You know, again, my first question is this margin out too far? You know, I don't have the CEREC data to be able to critique that, but assuming that this margin is drawn correctly, I would say that the implant position being right here is more proper. So no problem. Now let's look at the implant length. We have a 5 by 11.5. 5 millimeters ideal for a molar. 11.5 is more than adequate for a molar. If we went to that is too close. No question about it. I would say that this is more than fine, more than safe with guided surgery, traditional OptiGat, CCAT guided surgery. If you were doing CEREC guide on this, I would say that there's a little more margin for error. I may not go with this length. I may go with this length for a CEREC guide, but with a CCAT, traditional CCAT guide, I have zero issue going with an 11.5 millimeter implant here. So again, everything looks very good. You know, the last thing I just like to check is let's go over here and clip along the active slice, and we'll kind of take a look at our case right here. And again, you know, the only thing I can say if we look at it from this angle is not much. You know, not much here. Again, you know, I'm a little concerned if that buccal margin was drawn too apical. That may be the case. Let's see here if we show it there. Will we get a better view of it? And yes. So another good lesson here is if we take a closer look at this, we can, and looking at it from this angle, we can see that our gingival margin is right here. Right there. Okay, so it's unlikely that our gingival margin will then drop that low. So I would say that more than likely this gingival margin needs to be probably right there on that line. So when doing this SSI determination, when you're doing on the CEREC side, make sure that we mark that margin correctly, because certainly that will affect our proposal, which will then affect our implant plan. So again, just you know, unfortunately we have to be a little bit critical here, but I would say that we need to have this a bit more accurate. Again, this is why I'm such a stickler about having the data proper on all these cases. So again, the implant plan itself is fantastic. And so if we had our margin here, we would see that we have more room to build the emergence profile even with a slightly higher placement. But again, going with this, I think your plan is absolutely excellent right here. The only thing I would say in looking at this is when we look at it from this angle right here, you know, we know that lower teeth are tipped in a little bit. This implant looks to be coming straight out, and we can see our tooth is properly designed and tipped that way. So more than likely, I would probably just tip that implant slightly that way. Now we're going to come to the central groove, and we're going to have a little bit more space there. So let's take 2 seconds to look at this a little bit closer. Let's take a look from right here. We know that our lower teeth, as you can see here, are tilted in as we go more posterior. So our implant in an ideal world should also follow that as well. So as we take a look at this, I think one, we may be a little bit thin here. We're not, but you know, one could assume that it's not centered ideally. So I think if we take this implant plan and just tilt it a hair to the lingual there, we gain more space, better centered, and now we're also coming through the central groove of the tooth, and the implant is slightly tipped. So let's take a look at this view here. Here's the old position, and here's the old position compared to the new position being right there. So maybe that's the only modification I would make on this plan. Thank you very much for your time, and have a great day.